All right, I'm sure people will continue to keep trickling in, just like in real life conferences. I'm Christian Rose. I'm going to be moderating this session, which I'm really excited about, incorporating implementation science into your global emergency care toolkit. I'll let the team do the introductions for themselves on their next slide, but I'm really excited to hear what you guys have to say. Thanks for being here.
Yeah. Thanks, Christian, and thanks everybody for attending our didactic. For those of you who may not be global health, sort of folks, I think the principles and the concepts will map nicely to domestic-based emergency care as well. So we'll do a round of introductions from left to right.
Hey everybody, good afternoon. My name is Taylor Burkholder. I'm an assistant professor of emergency medicine at the University of Southern California and have a particular interest in implementation science as it relates to health systems development.
And I'd like to introduce Dr. Shaheem DeFries, who's the medical director of the Western Cape Government EMS system, which is in South Africa. He's 8 hours ahead in Cape Town, and so he was gracious enough to pre-record his lecture for us, so we'll be playing that later on.
My name is Julia Dixon. I'm an assistant professor at the University of Colorado in Denver, and most of my work revolves around education of both healthcare providers in the US who are going to volunteer abroad and healthcare providers, nurses, and physicians internationally.
And I'm Kofi Mold-Millman. I'm an associate professor of emergency medicine. I'm also a global health physician investigator. My areas of interest are pre-hospital care, trauma, and early resuscitation, and sort of have a heavy focus on educational interventions and innovations. Collectively, we have no conflicts or relevant disclosures. So broadly speaking, our goal is to help demonstrate to you that implementation science can enhance your global emergency care work. And we're going to do this by reviewing some key implementation science concepts, theories, and frameworks. And then we're going to do 3 case studies where we'll show some applications and approaches in implementation science for global EC work. And then we'll end up by providing you some training and technical resources and hopefully have a good discussion. The structure of the presentation, the didactic, is as follows. I'll do an initial introduction, and then we'll have a second segment of 3 case studies in education, systems development, and we'll have a South African stakeholder present their perspective, sort of their organizational perspective. And then we'll conclude with a question and answer session. So to kick us off, I think it's no surprise that historically a lot of biomedical research has been done in sort of very pristine clinical settings, so to speak, that really are not reflective of real life clinical settings. So for example, a clinical trial selects a very high performing clinic. They select practitioners who are fairly exceptional. The research team brings in research assistants to help support the intervention. The inclusion-exclusion criteria can be quite restrictive. And coupled with all the other factors you see on this diagram over here, I think that it's not surprising that it takes 17 years for 14% of original research to get translated to patient care. In global health work, because we have to go an extra step of adapting interventions or practices from high-income settings to low-income settings, there's a further delay, and we think the gap, the knowledge to practice gap that exists is further magnified in resource-limited settings. So this is the role of, I think, implementation science, is to help narrow and to bridge this gap. And it's not surprising or coincidental that the first and second editions of the leading textbook in dissemination implementation science actually feature a picture of a bridge. I think it's symbolic and represents the role that implementation science exists. So these are some of the key concepts and terms I'd like to review. I'm going to sort of run through these in subsequent slides. However, there's a quick footnote, which is we will interchangeably use the following terms: dissemination and implementation, which is D&I, synonymously with implementation science, or IS. And then outside the US, this field is often called knowledge translation. So just a quick disclaimer. The concept of an evidence-based intervention or practice is really core and central to implementation science. The rationale being that it is strongly preferred and desirable to implement those interventions or practices for which there is some critical amount of data or evidence to suggest that they actually are efficacious. So we'll often refer to evidence-based interventions in this presentation. There's a distinction between an implementation and dissemination, and an implementation is essentially the act of introducing an evidence-based intervention into a specific clinic, practice, population of providers, or a facility, for example. Whereas dissemination is the targeted and planned distribution of an evidence-based practice or intervention to other populations, to other hospitals, other health systems, other countries, perhaps. We often think of the intervention as the what, the thing that is getting implemented there, whereas the implementation strategy is often thought of as the how. So for example, if we wanted to implement a basic bundle of sepsis care, say in a district hospital in Malawi, the 3 or 4 items in the bundle of care would be the what, the thing, the intervention that we wanted to implement, hopefully with some evidence associated with it. And the how, would be if we chose, for example, an educational intervention or a sensitization program, or if we decided to use an audit and feedback program as a method of, introducing the sepsis bundle, that would be the implementation strategy. And this is quite relevant because implementation science uses hybrid designs to separately assess the outcomes from the what versus the how. So on the left is what we think of as sort of traditional biomedical research, which focuses on clinical effectiveness. And all the way on the right is more implementation science sort of friendly research, which is the how. How do we get the thing into practice? And in the middle, there are these design types called hybrid type 2 designs, which equally have an equal focus on both the what and the how. And so this slide is just to expose you to that a design exists for this purpose. And because answering why interventions succeed and are sustained and thrive in certain settings, implementation science tends to be very friendly to mixed methods research, which is blending the quantitative with the qualitative. And the qualitative really helps us sink our teeth into why is it that an intervention may thrive or fail in a clinical site. And I think this likely resonates with all of us who do global health. There's this constant tension between fidelity and adaptation. And fidelity is implementing a program, for example, as it was originally intended, whereas adaptation is the purposeful changing and modification. And I think in global health work, it is important to contextually and culturally adapt an evidence-based intervention so it makes sense for the environment in which we're going to implement it. So an example would be the World Health Organization's Basic Emergency Care course. In its original version, if we implemented with fidelity, we would do it 5 days straight using a train-the-trainer sort of approach as prescribed in the BEC manual. However, if we adapted our strategy, we would perhaps do a 1-day-a-week intervention, training modules, and maybe we would do them in a clinical setting and not in a classroom. And so that would be an example of an adaptation. Implementation science says that's welcomed and that's fine insofar as you catalog and systematically document all the changes you make and measure the outcomes associated with your adapted intervention. This phrase is used very commonly in the field, which is context is everything. You'll see frequently, if you look at implementation science models and frameworks, that there are various levels represented, starting from the individual, extending out to the community, the healthcare setting, and all the way up to the national or policy level in some instances. And it's a reminder to us to think about how our intervention is impacted and influences each of these, strata of context. Another critical concept in implementation science is designing for dissemination and for sustainability from the get-go. From the moment an intervention or a program is conceived of, implementation science says start thinking about how this can be disseminated. What are the attributes of the program that are going to allow it to sustain over time in that context? last. I'm going to quickly review a few models, frameworks, and theories with you and set you up for the upcoming case studies. But why use these? And in brief, they help improve planning and preparation. They help us to define and measure our outcomes, and they improve our ability to engage our stakeholders at multiple levels, not just the providers we work with, but sort of all the spheres I showed you in the previous slide. They improve the scientific rigor of our work, and I think they definitely improve dissemination and sustainability. And last, I think they do increase the likelihood that we'll get funded and we'll get published using these techniques and methods. Nielsen and colleagues in 2015 sort of published a nice paper where they broke down all implementation science models, theories, and frameworks into these 5 categories. So EPIS is an example of a process model, and Dr. Dixon will give us a case study based on EPIS. Organizational readiness for change is a nice example of a classic theory in implementation science, and Dr. Burkholder will case study that for us. And last, Dr. Shaheen DeFries will give us the organizational perspective from a program in which we use the REAIM framework. So with that said, I would like to turn it over to Dr. Dixon for the next segment.
Great, thanks for that introduction. So I'm going to talk a little bit about applying implementation science to an educational intervention. Next slide, please. We are going to use the EPIS framework, which stands for Exploration, Preparation, Implementation, and Sustainment. This is really the way that most of us already approach our global health work, as well as educational interventions in general. But the benefit of using a framework is that it adds rigor. It also makes sure that you don't miss any of the components. And then I think just provides a really good framework for talking about the work that you've done so that you can really explain how comprehensive your project was. Within that EPIS cycle is the inner context, the outer context, bridging factors, which in academic medicine often means a relationship between a university and a Ministry of Health, or a university and an NGO, or a university and another sort of grant agency. And then for educational interventions in particular, innovation factors can be very important. So who is delivering the content or how you're delivering that educational content. Next slide. So for this case study, the intervention was the WHO Basic Emergency Care course. It was delivered relatively close to the intended 5-day intensive framework. And we used a train the trainer model, and it was a hybrid type 2 design. So in an educational perspective, hybrid type 1 would be if you developed multiple education programs and you wanted to compare them. And then a hybrid type 3 would be if you've already identified your educational intervention and you really want to know how to implement it on a much broader scale. And we did do a mixed methods evaluation. Next slide. So for our intervention, outcomes were pretty traditional educational outcomes, so pre and post test scores, some confidence intervals. We also got structured feedback from participants. This particular project did also collect data on pre and post patient outcomes. And then there were several implementation outcomes, including the number of providers who were trained and new trainers. Additionally, we also kept track of the cost of our intervention, and cost effectiveness is a key component of implementation science and is actually its own field within implementation science, but it's something I think we need to work on in global health. Next slide, please. So going back to that EPIS framework and thinking about this case study in particular, things that would be relevant to the inner context are local leadership, characteristics of the healthcare workers, both the learners and the trainers, characteristics of the hospitals, and then resource availability, not related to the clinical care that was being provided, but related to the training. So did you have adequate mannequins? Did we have the funding for lunches and per diems if that was needed? Relevant factors for the outer context included leadership at the Ministry of Health, general emergency care policies, and funding for emergency care development, and just general advocacy for healthcare workers and patients. The main bridging factors were the relationship between several universities and the Ministry of Health, as well as the African Federation for Emergency Medicine, which is AFEM. And then for our particular case study, their innovation factors didn't play as significant of a role. We delivered the course over those 5 days as originally intended, but this could kind of change depending on your educational intervention. Next slide, please. So often when we think about implementation science, we have our kind of our project and our desired outcomes, and we have our framework. But ultimately, where it all starts to come together is in the logic model. And your logic model can usually have several. You can have a big picture one, and then you also have one that gets into the nitty-gritty details of everything. So within these 4 phases of this, there's components related to the strategies you're using, as well as the outcomes that you're going to be looking at. So in the exploration phase, you're engaging stakeholders, you're selecting your sites, and when you're thinking about outcomes, you want to know the feasibility of collecting that data, and in this case, patient outcome data, and then making sure that you know what your stakeholders' desired outcomes are. For preparation, this is, I think, a phase a lot of us are intimately familiar with. So lots of logistics, lots of little details and planning, and determining really how much adaptation you're going to need to do. And then you're doing a lot of preparation work so that you can adequately and meaningfully collect data that's relevant to your outcomes. For this project, implementation was using a train the trainer model. So local healthcare providers participated in a training course and then co-delivered the content for each of the courses. And then during the implementation phase, we collected our intervention short-term outcome data, so the pre and post test scores. And then sustainment was thinking about future courses as well as modification of any of the content to the local context. I've added modules at the request of local facilities or ministries of health, and then really starting to build your dissemination plan. And then another critical component of sustainment is really evaluating the implementation and determining if anything about your implementation strategy needs to change, and to keep identifying what you need to keep that's making it work. At the very bottom is that bar, that's the inner and outer context, and because that really that plays into every aspect of this at this framework. So the next slide is really just it's another logic model. It's not relevant to this project, but I just wanted to show you that some logic models can be a lot more interconnected. Arrows can go forwards and backwards, and you can get quite detailed. Next slide. The final point that I want to leave you guys with, especially as it relates to educational interventions, is just designing for dissemination and sustainability. So the dissemination piece means some of the key things are that it really has to be context appropriate. You have to make sure that it's addressing a need, that the target audience actually thinks of a need, and then you have to measure meaningful intervention outcomes. So going a little bit beyond just pre and post test scores. And then for sustainability, I think the most important thing is building local capacity. And further than that, I think it's building local leadership. So in Uganda, there was a pair of nurses who really took off with BEC after they were trainers, and they did their own kind of continuing education modules and made changes within their departments. And they were able to present their work at the AFEM conference in Rwanda. And they've continued to go on and build really strong kind of training programs at their hospitals. And we measured improvement in patient outcomes. And so building the leadership, I think, is sometimes the hardest part, but really the most important part, and what allows it to succeed kind of beyond your intervention. The other thing is, for sustainability, is really having a clear kind of final outcome and goal in mind. So very brief case study. Happy to answer questions at the end.
All right. Thank you to Dr. Dixon for presenting that really nice example of harnessing implementation science process models for educational programs. I'd like to spend a few minutes on our discussion for a project that is currently under development with a particular focus on how we can use implementation science theories to plan and execute projects more rigorously. Next slide. The particular project I'd like to discuss is one that will hopefully launch this summer earlier in the fall in Zambia, and it's driven by a request from the Ministry of Health to implement a standardized triage tool, much like the one shown here, across all district hospitals in Zambia. But first, it will start with a pilot in a select few hospitals. From personal experience by myself and some of our other research team members implementing triage in other countries in sub-Saharan Africa, we've realized that it's not as simple as plugging in the tool, teaching the nurses and the doctors how to use it. Some facilities simply weren't as ready for implementing triage. It became some of our anecdotal experiences. We don't know exactly why some hospitals are less ready to implement the triage tool than others. So the aim of this particular project will be to assess the degree of organizational readiness for change, or implementing a change such as this triage tool, and then use that information to identify barriers and facilitators to implementation in order to improve the implementation process prior to beginning. Next slide. In order to do that, it's helpful to look to theory to form the foundation of our work, and that's why we're heavily using this as an example for theory to set us up for success. The theory of organizational readiness for change jumps out because it helps us analyze the specific questions we have in mind. Specifically, we want to know how the workforce thinking and culture will respond to the proposed intervention, the triage tool. So we'll look to psychological concepts on the super individual or group level. Then we want a theory that helps us make sense of how well the intervention fits with the sites that are going to implement it, and will help us predict the success of implementation to some extent. And then it'll also help us predict barriers and facilitators before the implementation begins, so we can find solutions to the barriers and leverage the facilitators in our process. Next slide. So we decided to draw on the theory of organizational readiness for change, or ORC, by an organizational psychologist and implementation scientist named Brian Weiner. His theory is the most widely validated that we found, and focuses on whether or not group members are psychologically and behaviorally prepared to take action. In his theory, he starts by looking at two major facets of organizational readiness. The first is change commitment, which refers to the members' shared resolve to implement the change. In other words, how badly do they want the change? And then the second is change efficacy, which is the members' shared belief in their ability to implement the change. Put simply, that's how well do they think they can manage what needs to get done. Weiner's theory further outlines a bunch of determinants for each of these facets, which yields a very handy framework for designing a study to assess each of those in turn. Next slide. In applying the theory of organizational readiness to change to implementing a standardized triage tool in this setting, we started by mapping the determinants to the implementation plan, and then ultimately to the downstream implementation outcomes. On the left, we include the applicable determinants of organizational readiness. As you can tell, these aren't necessarily project specific, but they will be useful in processing and packaging our findings into an actionable implementation plan at the end. For example, change valence, which is essentially how much members value a change, influences their change commitment prior to implementing triage. So we need to assess whether they think the change is needed, beneficial, and or worthwhile. Leadership support influences the change efficacy, or how successful they anticipate the change will be. So we need to inquire about how supported they feel from the top down. If we want to look at whether or not they understand what tasks need to be done, we have to ask them about the tasks. And if we would need to know about the resource availability, we have to ask them if they feel that they have the resources that are needed. We can track that to the downstream effects on the implementation outcomes. In this case, is the triage tool successfully implemented and used? And then later to the effectiveness of the intervention on things like early identification of high acuity presentations, decreased time to provider, reduction in ED mortality, and a little bit more difficult to measure optimal resource utilization. Next slide. Ultimately, there are a bunch of tools that help us operationalize the theory itself. We specifically wanted to find a tool that is grounded in our theory of choice, is studied at the super individual or group level, and one that is psychometrically validated for this type of work. We found a bunch of different tools, some of which are even integrated into D&I frameworks. For example, the ORCA tool is associated with the PARAS framework. So if you're using that, it makes sense to merge the two. But it largely focuses on the leadership level of an organization. And in something like this that will have a lot of involvement from the frontline workers, it doesn't seem to fit as well. Another widely used one that you'll see in the literature is the Texas Christian University ORC tool. But it's only applicable to mental health and substance abuse programs, and it's not readily modifiable. So we realized it wouldn't fit our needs either. Next slide. Ultimately, we chose this one, which is the ORIC instrument, or the Organizational Readiness for Implementing Change. It's a very simple 10-item survey-based tool using 5-point Likert scales, which give a nice assessment of both of the facets of ORC in a quantitative manner. It allows us to assess readiness of each of the facets by the median response to each of the questions, as well as their inter-rater agreement. And it's quick, easy to use, ties in directly to Wiener's theory, and he has psychometrically validated it with subsequent external validation as well. Although this tool yields a quantitative score for readiness, and that will help us predict overall chances of success and the fit of the intervention to the sites being studied, it doesn't give the qualitative information that we need to identify barriers and facilitators, which is the second part of our aims. So to do that, we have to devise a follow-up method to get the information and stay in line with our foundational theory that we're using. On the next slide. This is a map of the methods that we're proposing and planning to follow. It's a two-part mixed methods approach where we first use the ORIC survey instrument and we'll send it to key stakeholders at each of the sites. And from their responses, we'll be able to calculate median readiness scores and their inter-rater agreement. And with that data, we'll then be able to conduct focus groups. And for those focus groups, we'll have an adaptive focus group interview guide that will help us target those constructs that showed the least readiness or the most disagreement on the ORIC survey instrument. Once we have that information transcribed and coded, we'll be able to analyze for themes that help us identify the barriers and facilitators to implementation, which we hope to rapidly feed back into our implementation process even before it begins to make adjustments as the triage tool is rolled out, and hopefully again when it is all disseminated. Next slide. So it was a very rapid fire overview of what we're planning to do, but I hope that it illustrates that D&I theories can be powerful foundations for our implementation analysis. They can really help us make sense of the world that we are studying. And luckily, some theories even have validated instruments that really help us operationalize it in a quick way. So you don't have to get so bogged down in the theory itself. But finally, when it comes time to actually package and make sense of your complex qualitative findings and present those back to the stakeholders that will be using this, it can be very helpful for presenting it in a logical sequence that can be validated by your experience and your research. And that's it.
Thank you, Dr. Burkholder. That was an elegant example of a theory in D&I. What I'd like to do now is we're going to switch gears a little bit. You've heard the researcher's perspective on frameworks, theories, and implementation science. I'm now going to play you a video from a South African head of a large EMS organization. And before I do that, I'm just going to provide you a little bit of context about the project so you can better sort of understand his quick video. So this is a longstanding collaboration between myself and Western Cape EMS, specifically our sort of departments or organizations collaborate around trauma care. In 2016, we launched a federally funded project with a joint goal of improving clinical outcomes for trauma patients who are in hemorrhagic shock. The intervention that we decided upon was a basic bundle of EMS resuscitative care. The outcome of that intervention was a change in shock index during the pre-hospital transportation. The implementation strategy broadly was an educational approach. However, we decided for many reasons that we did not want to do another classroom-based intervention that was expensive, unsustainable, and a long list of issues which I'm sure you're all familiar with. Instead, we decided to test sort of a novel approach, something sort of I'd been grappling with for a few years. And this is an on-site, low-dose, high-frequency training program. It happens in the back of ambulances for a few minutes, once a week, with EMS providers using peers, paramedics to train EMTs. And the outcomes of our implementation strategy were really around implementation effectiveness. And we used the, I'm just going to jump one slide here. We used the re-aim framework, we as sort of the research team. And we picked this. This is arguably one of the most widely used and widely known frameworks in implementation science. In part because it's easy to understand and communicate and easy to use, and it's used for both planning and evaluation. The top two constructs are at the individual level. The bottom three constructs are at the organizational level. So reaches your ability to, the proportion of patients or providers you reached. Efficacy is really around the effectiveness of the patient or provider level. And these are organizational outcomes. How likely were they to adopt the implementation? Was the program implemented with fidelity? And what was the maintenance after 6 months or longer? So just a little bit about the background. And just to let you all know, we did use a lot of D&I approaches in this project and principles, including stakeholder discovery and engagement. We embedded our research team with the organizational team. We used concepts like designing for dissemination and sustainability. And we embraced the messiness of real life, of real life practice. And we did not have very stringent criteria for participation in this study. And so with that in mind, I'm now going to present Dr. Shaheem DeFries's presentation. Please let me know if this does not transmit.
Morning, everyone. And firstly, thank you to Nico, for you, to Julia, and to Taylor for inviting me to be a part of this great talk. My name is Dr. Shaheem DeFries. I'm the Medical Director for the Emergency Medical Services of the Western Cape. So I'm no implementation science expert, and was led largely by the team. But I do think there's so much to be gained in sharing some of our insights and experience as part of that. So a little bit about my service. We are one of 9 provincial services or state services in South Africa. We're fairly large by US standards. We cover a jurisdiction of about 130,000 square kilometers with about 60 bases spread across that footprint. I have a staff complement of about 2,000 staff and an ambulance fleet size of approximately 260 ambulances. South Africa has fairly large trauma loads, and we are no exception. We have approximately 600,000 cases a year of medical and trauma forms a large chunk of that. Like every African country, we have significant resource limitations, but to be honest, we're fairly well resourced by African standards. When Kofi approached me around the project and what he had in mind, I think there were many things that resonated really strongly with me. Not least of which was the impact on clinical care. But certainly in an organization such as ours, communication is critically critical and quite a challenge when dealing with such a geographic footprint and a dispersed workforce. So looking at communication, building a more resilient workforce, and in particular, when you are in the service industry, your personnel component is a great determinant of the quality of your service. And so much gets invested in training practitioners and keeping them skilled. And for a service with our kind of logistic challenge, this can be quite expensive. So we were looking at ways in which we could do this more efficiently and effectively. So the team will speak about the research goals, but largely they will look at how do you implement a bundle of trauma care using such a novel education or training approach. And then secondly, what is the outcomes of such a program? In particular, can we see any outcomes in where it matters, which is in the patient care? But the organizational goals are more what drew me into the program. In particular, trying to not just improve clinical care, but what could it mean for creating connection, for creating collaboration, for creating a more effective and trusting workforce within an organization such as ours. So a little bit about how we did it. So HEAT is in essence a low dose, high frequency program. By low dose, what we mean is it had to fit within the working day of a service like ours, and it had to have very minimal impact on that day. So ultimately, it meant, you know, teaching the objectives within 15 to 20 minutes just before shift. Tightly compressed timeframes. You had to have more frequent training sessions, and so weekly to bi-weekly sessions were often had. One of what I feel is the most powerful characteristic of HEAT or HEAT-like training is its contextual relevance or contextual sensitivity. And this extends not just to what we teach and where we teach it, but also who teaches it. And so the HEAT program was peer-driven and occurred in the back of our ambulances, in the crew's own vehicle with their own equipment that was at hand. And you know, the collaboration extended not just to the content, but also how the content was designed, and even there we had to pay particular attention to the contextual sensitivities. So yeah, I mean, I can speak to what it meant for how the organization benefited, but since I have very little time, I'm going to jump straight to proof that these lessons were in fact gained. And I'm going to talk a little bit about our COVID experience with HEAT. So, you know, we wrapped up HEAT towards the end of December of 2019, and in 2020, sort of started getting back to routine training. And with what happened in China, there was like with everyone, you know, across the globe, we needed to train up our practitioners around infectious disease and biological agents. And I was starting to meet with teams, as in these pictures, to deal with fear. You know, these engagements were quite contentious. Trust was a major factor. And the consequences of failure were evident, you know. In fact, so where does HEAT fit into this? Well, in fact, what it done is the same team that developed the HEAT content developed 3 modules, looking at IPC, looking at clinical care, looking at decontamination, and these were designed along the same principles as HEAT. They were contextually relevant. Occurred in small numbers, peer-driven, and usually, you know, compressed timeframes of 15 to 20 minutes. And these fitted so beautifully into what we needed to do at the time when such a lot of pressure was placed on a service like ours. In my view, we were able to build and leverage trust in a way that we simply would not be able to do that if we had to bring people into a classroom. You know, now it's quite easy for us to do virtually. Back then, you know, a year ago, you know, virtual was something completely novel. And so to get practitioners to engage with that and still build trust and still deal with fear and still get a service out in 15, 20 minutes would not have been possible. And really, to my mind, illustrated this idea of dynamic capabilities that we got in addition to the insights through HEAT program, you know. So yeah, I mean, really incredible program in total, and so glad that we were able to draw on the lessons and the skills that we were developed over time. And in my mind, it doesn't get better than that in terms of implementation science. Really proud to have been part of that. So thanks. With that, I'll hand back over to Kofi and the team. Morning, everyone, and firstly, thank you to Nico.
Yeah. So just to summarize, implementation science principles and approaches allowed us to embed our research program and weave it into the fabric of the EMS organization and purposefully build capacity and build a team that was skilled to be able to run their own programs the instant our research study was done. And I think as global health folks, we think about doing this all the time, but really implementation science armed me with the tools and the approaches I need to have done this successfully. And so I think you heard the organizational sort of perspective. So with that, we'd like to maybe commence, we'll stop and then turn it over to Dr. Rose for his comments and questions.
Wonderful discussions. Everyone's topics were really great. I especially like the general outline. We didn't have any major questions from the crowd, but one that I think you kind of are getting to in the way you even laid this out, but it's sort of the chicken and egg issue of any intervention, but especially in global health, where you have different stakeholders, you have an intervention that's proven itself somewhere, then you either have a stepped wedge approach or you choose different sites. Do you maybe have like a 30,000-foot view of kind of where you start? Do you start with the stakeholders and what their needs are and build something out? Or for the most part, you guys as a team, do you look at like, hey, here's some of the things that have proven out and how are we disseminated? Are we in those middle steps of the stepped wedge? Just to get a little bit of perspective on that.
Who wants to take that?
Thanks for that question. Well, I think so in true implementation science fashion, it depends. It really depends on what your starting point is. So if your stakeholders have like a general need, then the answer is kind of you start with that stakeholder engagement and figuring out exactly what a need is. I think from, take for example, the educational intervention we had this course that they wanted to deliver. And so you're kind of in the middle, so you don't really get to say, kind of exactly how the course is delivered or who's going to do it. There's been some kind of predetermined things by your partners or just by your constraints of like the project and what the ask is. And so I think you really do your best to apply implementation science, I think, to the evaluation is where that comes in. So you may not have a lot of control over the intervention itself, but you can certainly make the evaluation more rigorous, and then you're setting yourself up to engage in a more thoughtful way moving forward, and you're able to come to your stakeholders with good feedback about what is maybe actually needed.
Yeah, I think that's a really important point, and I think like all things, we should be decolonizing our approach to global health research. And so the start is always with the stakeholder and your on-the-ground partners and what's needed and wanted. But it does matter, is it an implementation strategy they're looking for, or in the case of you're saying if it's moving and disseminating somewhere else, and that's maybe a little bit more on the dissemination side, and there might be some theories and frameworks that are more dissemination oriented than truly implementation, or some mix of the two. So I think it's pretty important to consider, especially if you are thinking about like a quasi-experimental strategy, like a step wedge or a time series or anything like that. Then I'd usually kind of approach it for what is our aim or our collective aim with ourselves and our partners.
So in our educational intervention, I could tell that there was a little bit of skepticism as to whether or not this was really feasible to teach and train EMTs and paramedics in the back of ambulances for 15 minutes once a week. And the team was also concerned about the efficacy, educational efficacy. So we started out by some really simple pilots, like we would go to a base and round up a crew, get them in the back of the ambulance and do a dry run, just to demonstrate to my stakeholders, actually, this is doable. So once they bought into that, then we embarked on the next step. We took a whole base offline. We brought them online, and we implemented our intervention on a pilot test basis. And so we ramped up gradually, building the evidence in the team's experience and confidence before we launched our quasi-experimental trial, in the system. And that's very much in line, I think, with implementation science thinking and approaches.
I agree. I think that one of the things that's very interesting to me, having worked on similar projects also related to the BEC, also with Shaheem and Western Cape people, as well as you will have an intervention and you can have a participatory model. And the very nature of the fact of global health, just reflecting back the implementation science on global health, is that you got very many different discrete needs. So your options were either try to, the tension was talked about earlier, try to maintain the original model and ask the groups to adapt to it, or you let them adapt, in which case you've got a lot of varied implementations. Most people, and I'm sure most of the classic researchers, see that as sort of like a breakdown. But I think one of the important lessons from a lot of the implementation science is just which I tell to some of the residents and trainees and people when they go, like, to just take the feedback, you put it in, and you can continue to present it later. That's not, it's a perceived tension, but I don't know how you guys feel. It's not always necessarily real, although it does get a little hard to write your mixed methods papers when you've got different data all over the place and different scales. Let's see.
Agreed.
Yeah. I guess we can, we got a couple more minutes too. I was going to say, you touched on a little bit of re-aim. I really like the readiness for change model too. I think one of the things I'm sure some audiences, our members would feel too is, you come in with some expectations of an institution, but unless, again, you're meeting them at a time and a place where they're ready to implement, you can always come back. You can always do things later. I think a lot of the scientific research also assumes a sort of one-to-one ready try, but being able to assess these things and recheck in is an important takeaway from a talk like this. And then what is, to you guys, what's your favorite for global health purposes, given all the things we've talked about? Obviously, the implementation model is determined by what your intervention is. But are there any new things like pre-seed, proceed? Are there ones that you feel like the audience from here should take away, and look at this implementation model for the average kind of projects you're seeing? I know it's a loaded question, but just curious.
I guess I'm gonna give kind of like I would say, don't start with CFR. Start with something more straightforward. That's actually my advice, is to start with something like re-aim. Don't start with the biggest, broadest thing out there.
That's a good lesson. Even that one will at least give you some focus by taking away one of the things from the differential.
Along those lines, are there any particular early steps in terms of research or projects that you would suggest to either pursue or avoid? I had done a implementation science course to the University of Washington, which was great and gave me kind of a foundational background framework, but haven't really had a explicit opportunity to pursue. And so is it just finding the right mentors, or what would you kind of say beyond just avoiding CFR as your first step, is a objective next step?
I can start as I think someone who's most junior and new to the idea of implementation science. I also took the same intensive course at University of Washington, which I think that plus working on a few projects with mentors like Nikofi and some other research mentors internationally got me excited about the idea of implementation science. And then I started looking at these kinds of resources that Dr. Molden-Millman has on the slides right now. And then I think it's about reaching out for mentorship with specific implementation scientists when I start to work or collaborate on a project. I've been learning a lot as I go by trial and error. And then there are quite a few amazing certificate programs, if you don't want to say do a master's or a doctorate in implementation science, that are available. And so those are worth looking at as well if you're thinking about taking it to the next step.
I think I would add to that, either if finding a mentored project to be part of is really the best way to learn on how to do these projects, because there's too many moving parts. So, but if you do decide to do a project on your own, I think my advice is to sort of try to keep it really short and sweet. So keep it as small and as concise as possible, but really getting involved in a mentored project is going to be your steepest learning curve.
Yeah, we've got to get going off on the last minute here, unless someone has another question, which feel free to raise, but I would like to echo that too. I think, at least from my experience again, which is that just trying and seeing. I think that these models can actually seem quite big and seem like there's just too many variables and so many things to go after. But realistically, they actually exist to try to simplify things and give you models of questions and how to ask and think about what might be important pieces of information to gain when you then go do your intervention. So it can be helpful at any sort of stage in whatever project it is, but just looking at them and actually just digging down and using them as a model is not as crazy as it might seem. It's not as like huge an issue. It can help really solidify very concrete questions. Don't be afraid of implementation science.
Yeah, and sometimes an easy way is look at a few papers that have been published, using the framework you're interested in, and it'll give you a really concrete idea of, okay, I see how I can kind of operationalize this into my research study or my global health application. So that's been really useful for me, especially if I couldn't necessarily find a mentor or an expert in that area. So just something to consider.
And there are actually meta papers out where people show you how to do an implementation science paper by doing an implementation of a model, which is like extremely helpful too. I completely agree with Nikofi.
Super helpful.
Right.
Thank you, guys.
Any last messages or last words from everybody? Otherwise, we're right on the dot here.
Cool. Thanks so much. That was fantastic.
Thanks for joining us.
Thank you.